Hello everyone, welcome back. Today I will be covering regarding parathyroid hormone (PTH). Started off with an introduction, the target organs, pathology, clinical features regarding hyperparathyroidism and hypoparathyroidism. As an introduction, parathyroid hormone is a regulator of calcium exchange. The fall in plasma ionized calcium stimulate the production and vice versa. Parathyroid hormone is a polypeptide that is synthesized and cleared into and cleaved into an active form within the parathyroid gland. An active parathyroid hormone secretion can occur as quickly as few seconds when low calcium is detected. Mechanism of secretion is via exocytosis. Serum half-life of the activated parathyroid hormone is a few minutes and is removed from the serum quickly by the kidney and liver. This picture illustrates the thyroid gland, the front view, and the back view of the thyroid gland. The parathyroid gland's location is as illustrated. The target organs of the parathyroid hormone: the kidney, the bone, and the gastrointestinal system. For A, kidney. The physiologic calcium reabsorption in the nephron takes place in the proximal convoluted tubule and at the ascending loop of Henle. Like the sodium, over 99% of the filtered calcium is reabsorbed, leaving less than 1% to be excreted. Calcium reabsorption is tightly coupled with sodium reabsorption in the proximal tubule and loop of Henle, and only in the distal tubule is the reabsorption of the two ions dissociated. One, in renal tubules, they will be reduced in phosphate absorption, and will be an increase in calcium absorption. Number 2, in renal parenchyma, vitamin D hydroxylation from 25 hydroxylase to 125 hydroxy is picture illustrate the calcium handling of the nephron. Among the calcium excreted, 67% of the filtered load is absorbed at the proximal tubule. In the thick ascending loop, 25% of the filtered load is reabsorbed, while 8% of the filtered load is reabsorbed at the distal tubule. The excretion of calcium is less than 1%. The next target organ is B, bone. Parathyroid hormone stimulate the release of calcium in an indirect process through osteoclast, which leads to the reabsorption of the bones. Before the osteoclast activity, parathyroid hormone directly stimulate the osteoblasts, which increase their expression of the RANKL, allowing the differentiation of osteoblasts into osteocytes. This picture shows the action of parathyroid hormone on the osteoblasts and osteocytes for the calcium regulation process. Parathyroid hormone also inhibit the secretion of osteoprotein (OPG), allowing for preferential differentiation into osteoclasts. Osteoprotein (OPG) competitively bind with RANKL, diminishing the ability to form the osteoclast. osteoclasts remodel the bone's resorption by dissolution and degradation of hydroxyapatite and other organic material, releasing the calcium into the blood. This figure shows how does the parathyroid hormone acts on the osteoblasts and osteoclasts, etc. The next target organ is C, gut or small intestine, by indirect effect. Starting at the kidneys, the parathyroid hormone stimulates the production of 1-alpha hydroxylase in the proximal convoluted tubule. This enzyme catalyzes the synthesis of active vitamin D, 1,25 hydroxylase, from the inactive form of 25 hydroxylase. The active vitamin D plays a role in the calcium reabsorption in the distal convoluted tubule via calbindin D. In the small intestine, vitamin D allows the absorption of calcium through an active transcellular pathway and a passive paracellular pathway. This picture illustrates the action of parathyroid hormone with indirect effects to the GI system to increase the serum calcium level. Okay, everyone? The clinical significance of parathyroid hormone. 1. Calcium role. Calcium plays an integral part in the cardiac contraction. The contractility of the heart is predetermined by the availability and the role of calcium inside the myocardial cells. When there is an excess amount of calcium within the cardiac cells, contractility will increase. And similarly, when there is a lesser concentration of calcium within the cardiac cells, the contraction will reduce or decrease. This can potentially lead to a prolonged QT intervals seen on ECG. Extreme hypercalcemia effect on the myocardium can be manifested in the ECG changes, causing a very short QT intervals. This could potentially precipitate the onset of fatal arrhythmias such as ventricular tachycardia or even ventricular fibrillation. Abnormal oversecretion of parathyroid hormone, the source of bone degradation, will increase the calcium into the blood. This can facilitate premature susceptibility to premature transition into osteoporosis and increase susceptibility to fracture. Oops, sorry. Clinical significance in 2 calcium-related pathologies. Electrolyte hemostasis is crucial. Low levels of calcium cause nerve hyperexcitability at every levels of neurons throughout the nervous system. This is associated with reduce in the threshold potential in the presence of low levels of calcium. The sodium channels are open at a much lower membrane potential, requiring a smaller amount of stimulus. This figure illustrates the neuron, its action potential, and C, the spike train or activity with different stimulus levels and resulting calcium concentration C. Another clinical significance of parathyroid hormone is PTH and malignancy. In metastasis, bone is invaded by the cancer, stimulate the local osteolytic activity, and increase serum calcium levels. In breast and prostate CA, tumors may release 1-alpha hydroxylase, increase the synthesis of procalciol and allowing for excessive reabsorption of calcium. in bladder, kidney, ovarian, uterine, head and neck, lung and breast carcinomas where the primary tumor secretes a parathyroid hormone-related protein, PTHrP, while some sarcomas and hematological cancers are found to produce the protein sporadically. Clinical features of hypercalcemia. A. General. There is tiredness, dehydration, depression. B. The bone. Patient will have a bone pain. C. Renal. Patient presents with renal colic, polyuria, nocturia. D. Others. Abdominal pain, chondrocalcinosis, corneal calcification, ectopic calcification. Regarding hyperparathyroidism, it can be divided into primary, secondary, and tertiary cause. A. For primary hyperparathyroidism, it refers to an abnormality in the parathyroid gland itself, such as adenoma or hyperplasia, causing the gland to oversecrete. Adenoma can be sporadic and can be surgically resected. Hyperplasia found in multiple endocrine neoplasia, MEN type 1 and 2A. In MEN1, tumors in the pituitary gland, parathyroid gland, and pancreas. In MEN2A, this include medullary thyroid CA, pheochromocytoma, and parathyroid hyperplasia. B. Secondary hyperparathyroidism. It is a compensatory oversecretion of parathyroid hormone in response to abnormality low calcium in the blood due to renal failure, GI malabsorption, or simply a vitamin D deficiency. In chronic renal failure, elevated a parathyroid hormone but with decreased calcium and elevated phosphate. In malabsorption and vitamin D deficiency, there is an elevated parathyroid hormone but decreased the calcium and phosphate levels. C. Tertiary hyperparathyroidism is rare. Autonomous parathyroid hyperplasia, a continuous parathyroid hormone secretion after a long-standing secondary hyperparathyroidism due to renal failure cause. There will be moderately elevated parathyroid hormone, plasma calcium normal or elevated, decreased phosphate. This condition can be treated by parathyroidectomy. Bony changes in hyperparathyroidism. There is an increase in the ratio of osteoclast to osteoblast, decreased collagen by osteoblast, resorption of osseous tissue. The types of resorption: 1. Subperiosteal, 2. Intracortical, 3. Endosteal, 4. Subligamentous. Number 1. For subperiosteal erosion, the definition: loss of bone mass occurring beneath the periosteum. This is due to increased bone turnover. This process may create a serrated and lace-like appearance in the periosteal cortical bone. This is diagnostic or pathognomonic. Occur most frequently along the radial aspect of proximal phalanx of the middle finger and index finger. Other sites: middle aspect of the proximal tibia, femur, humerus, margin of the rib. This X-ray illustrates the subperiosteal erosion that occur at the middle finger and the ring finger. Number 2, intracortical erosion. It is an osteoclastic lesion. The X-ray will show an intracortical linear striation, salt and pepper skull, granular appearance with the loss of trabecular detail. The difference between the outer and inner table of skull is lost. Example in the brown tumor. This left radius and ulnar X-ray shows the brown tumors, black arrow in the ulnar with subperiosteal resorption seen by the red arrow. In brown tumor, apart from the intracortical erosion, there is a localized accumulation of fibrous tissue and giant cells. It replaces the bone and produces osseous expansion. It may also undergo necrosis, liquefaction, producing cysts. Single or multiple level defined lesion, axial or appendicular, eccentric or cortical. Involve the facial bones, the pelvis, the rib, and femur. There is a rugged jersey spine. This sagittal CT scan of the lumbosacral region shows the rugged jersey spine changes. Number 3, endosteal bone resorption, also an osteoclastic resorption. Focal resorption occurs at the inner layer of the cortex. Endosteal surface of bones, localized scallop along the inner margins of the cortex. This X-ray shows the endosteal scalloping and bone expansion from a phalangeal endochondroma. Number 4, subligamentous bone resorption. Subligamentous or subtendinous resorption can occur anywhere, but most common occurs at the calcaneus, clavicle, greater and lesser tuberosities of the humerus, greater and lesser trochanthus of the femur, anterior inferior iliac spine, and ischial tuberosity. This anterior posterior radiograph of the pelvis shows resorption at the right hamstring, the green arrow, and adductor origins, the red arrow on the ischial tuberosity. The treatment of hyperparathyroidism. The orthopedic treatment is protecting the soft bone from deforming stress and strain. Fracture occur, do an open reduction, internal fixation, or depends on the surgeon. After the disease progression arrested, recalcification occurs. Deformity corrected by osteotomy. Prognosis of hyperparathyroidism. Good prognosis occur after parathyroidectomy. The bone pain immediately abolished. There is a rapid and progressive healing of bones after the removal of tumor. Next, regarding the sign and symptom of hyperparathyroidism. The clinical features vary among the patient due to varying calcium concentration and renal complication. Hypocalcemic tetany, muscle excitability. Chopstack and Trousseau sign is positive. Trousseau sign denotes a painful caudal spasm caused by 3 minutes of blood pressure cuff inflation over the systolic pressure. Other clinical features are fatigue, hair loss, painful menstruation, brittle nails, and dry skin. This picture illustrates the brittle nails condition. I have shown in the previous video regarding the Chopstack and Trousseau sign. Treatment of hypoparathyroidism. depends on the primary pathology. But basically, administering a large quantities of vitamin D, which is 100,000 units per day, and 1 to 2 grams of calcium several times a day to maintain the average calcium ion concentration. Milk restriction, calcium supplementation, parenteral in tetany condition. Yes, we have reached to the end of this video. See you in the next one. Take care and bye.